Yeah. Today we're have the pleasure of having Dr. Speeg present to Transplant Grand Rounds. The majority of this audience knows Dr. Speeg. He's been with the university for a number of years. I suspect will continue to be with us in some form for a number more years. He is the chief and director, medical director of the liver transplant program, and I don't know, he says that's enough. So this talk was not approved by the Grand Rounds Committee, and I'm sure his opinions do not reflect those of the university. So.
What about the lights? All right. So the topic actually is marijuana use, not yours, but our patients. Okay, these are the disclosures that will be clear from the outset. I don't use it, I don't sell it, I don't grow it, but I do occasionally prescribe it, as I'll explain. So this is sort of the outline of the talk. I'm going to give you a short case, some background, some chemistry, and talk about the physical and mental problems with tetrahydrocannabinol and also cannabidiol. So let's start with a case which is sort of hard to decide where to put this, but I think you'll understand why I'm presenting it. This is a patient, those on the liver side probably know pretty well. She's a 34-year-old Hispanic lady. She got a liver transplant for Wilson's disease actually in 2009. An enormous amount of effort by a lot of people to get her through her end-stage liver disease, transplanted and taken care of afterwards. She did go back to school after the transplant and became a nurse, and she works in a dialysis unit. She had one episode of biopsy-proven acute cellular rejection in 2012. It just seemed to happen. She was treated with steroids, but it was bad enough that she needed 5 doses of thymoglobulin. She's being followed by a rheumatologist for osteoarthritis at age 34. And when we saw her in clinic in December 2014, she was complaining of severe left hip pain. By that time, she had already seen multiple orthopedists, told she needed a hip replacement, but she was too young to get one. It was news to me. After a lot of effort, surgery was finally scheduled, but during the pre-op screening, her drug of abuse screen came back positive for tetrahydrocannabinol, marijuana. And we found out that she'd been fired by her pain management physician, probably for non-compliance. And the next thing that happened was I get a call from her orthopedist who's really reluctant to proceed with the surgery. So what to do? Kick her to the curb? That was certainly considered. She hasn't used very good judgment. The other option was to waste a significant amount of time trying to convince the surgeon that actually the liver disease was not from something that she did, which is to trash her own liver, but instead a genetic illness, and probably her arthritis is also. Had to convince him that she's a compliant patient who will follow rehab instructions and take care of his hip. And that's the way he looked at it, and I can understand that because we've had other patients who have gotten either hips or knees. They don't do what they're asked to do. They come back complaining bitterly that didn't help me. He made a mistake. He measured it wrong. He did something. It's always the surgeon's fault, not theirs. So that's one of the dilemmas we have in the medical community with marijuana use. So really, why did I choose this subject? And the basic reason is I didn't know anything about it. Let me get right down to it. But we're asked to make decisions assuming that we do know something about it, and so that's why I did it. Opinions regarding use of marijuana are incredibly polarized, as you know. Here is a photo off the internet Actually, I thought this was Dr. Abrahamian. I'm sorry he left. Before he changed his appearance. He did change his appearance. Now he doesn't have hair and he has more of a beard. But actually, this was in 1970, and I realized he might be a little young then to actually have been in this picture. This was the Honor America Day, and the marijuana enthusiasts decided to protest in the reflecting pool on the mall in D.C. More recently, on April 20th, the famous marijuana date, this was in Denver. Tens of thousands were apparently there, according to the description. I actually thought this was perhaps one of our coordinators, but if you'll notice, she may be a Texas fan. The one I was thinking about went to A&M, so I guess not. But anyway, these individuals are probably not that interested in medical marijuana. Back at the ranch, closer to home, legislature is in session again. And every time they are in session, there's somebody that's trying to decriminalize marijuana possession. But our governor really likes the laws the way they are and probably would not be enthusiastic about changing them. So, more seriously, the real ethical consideration that I think we have to take into consideration is who are we giving livers to? And there are about 15,000 people on the liver waiting list in the United States. And the sad fact is about 2,000 of them will die every year waiting for a liver. So it's incumbent upon us to be good stewards of these organs. In our program, until fairly recently, marijuana or any illegal drug was considered a contraindication. It got you put in a 6-month hiatus off the waiting list. But more recently, we've evolved to basically considering marijuana as a relative contraindication. And there's a healthy discussion taking place as to whether it should not be a contraindication or no contraindication. Just so you know, most managed Medicaid providers, and we have lots of patients that have that, consider it a contraindication. So it's another level of discrimination which we usually go out of our way to avoid. Whether it's held against you depends on which insurance you have. So by way of background, it's important to understand marijuana is federally illegal in the United States. Medical marijuana use is actually legal in 23 states and the District of Columbia, but not in Texas. It's actually totally legal, including recreational use in Colorado, Washington, Alaska, and the District of Columbia now. Congress has expressed a desire to limit the Department of Justice from cracking down on the states that have approved medical marijuana. So that's sort of how the feds and the state can coexist on this issue. So how illegal is it in Texas? Lots. This is off of a lawyer's website, so I'm assuming it's probably accurate. Texas has a reputation for being extremely severe in its imposition of penalties for drug use and possession. It's not decriminalized in Texas, and Texas, like many states, uses how much do you have as to what the penalty is going to be. Now, one interesting feature apparently is that if you don't have any felony convictions and it's your first arrest for marijuana possession, it's less than a pound, then the judge will probably give you probation, but can demand that you enter drug rehab, which can be up to 1 or 2 years. There's also a penalty that ranges from $2,000 to $10,000 that he can impose if he feels like it. I don't know how many judges really are lenient when it comes to marijuana possession, but judges, like everybody else, eventually get audited and either scrutinized by their peers or skewered in the newspaper if they have not towed the letter of the law. How about giving marijuana to your friend or relative? It's not considered the same as possession, it's worse. And so you're much more likely to spend some jail time if this is what you've been arrested for. If you are selling it, then it depends on to whom you're selling it and where you're selling it. But this can be a really severe prison sentence if you're anywhere near the youth who like to use it. How about if you live in Colorado and you want to bring it to Texas? Well, better not. It's absolutely illegal and will be treated as possession. A doctor's excuse, even if it's legitimate in another state, is not a get-out-of-jail-free card here. So what about the chemistry? It's a plant that, when smoked, has about 4,000 chemicals in it, very similar actually to tobacco, and many of the chemicals are the same. Marijuana has over 100 cannabinoids, which are psychoactive, and the most psychoactive is THC, tetrahydrocannabinol. It's been around for a long time, first synthesized actually in 1964. It's actually available by prescription even here in Texas. It has been since about 1985. It's either as Marinol, which is dronabinol, or nabilone sesamate, which I'd never heard of. One's a Schedule 2, one's a Schedule 3, so it's easy to prescribe. It actually was approved for chemo-induced nausea and vomiting and stimulation of appetite in AIDS patients. Side effects of prescription dronabinol are drowsiness, unsteady gait, dizziness, inability to focus, confusion, mood changes, delusion, and hallucinations, or in the vernacular, being stoned. Now, there is a recent randomized, placebo-controlled crossover study of dronabinol for chronic pain. Unfortunately, or what they found was that it produced similar psychoactive effects as smoked marijuana and actually limited its usefulness as a pain medication. Now, another psychoactive drug or cannabinoid in marijuana is cannabidiol. It's first isolated in 1934 and synthesized in 1967. It's pretty much was off the radar until it was understood that it mitigated the euphoria caused by THC. Enter the genetic engineers. Bergdorf had access to marijuana that had been seized in California from about 1996 to 2008. And when analyzed, what he found was that the concentration of THC had increased over the years from about 2% to 10%. And supposedly there's marijuana out there that's got THC more like 15 to 20% these days. In addition, the concentration of the cannabidiol was decreased from 0.24% to 0.08%. So if you go to a pot shop, this is what you're looking for is the good stuff. Dr. Abrahami knows the names, but I don't. So the question arises then, is marijuana safe? And there are sort of two ways to look at it, mental health and physical health. There's little question that cannabis is addictive. It has its own withdrawal syndrome that includes irritability, nervousness, sleep difficulty, decreased appetite, restlessness, depressed mood, physical symptoms, and discomfort. It's got its own designation in the Sacred Psychiatry DSM-5. Depersonalization among cannabis users is pretty well established. And there really does seem to be a relationship between marijuana use and a number of psychopathologies and psychiatric conditions. lower concentrations of THC seem to be anxiolytic, whereas higher ones seem to cause anxiety. Consider what's happening with the THC concentration in marijuana these days. I should say, by the way, that marijuana that you can get, I'm told, can get from the border of Texas and Mexico is actually pretty well balanced in, it's the old marijuana. It's pretty well balanced in THC and CBD. And some of you may have seen a recent news alert on the internet that actually there is trafficking of marijuana from Texas into Mexico these days. It's the good stuff, though that has the either seeds or buds from plants with high THC levels. It's a new business venture down there. It seems there are reports. You have to realize most of the data that analyzes effects of marijuana are from recreational smokers. They're not great trials. There's not good scientific evidence for much of anything, I'm telling you. But long-term use of marijuana does increase your risk of depression, it's felt. It heightens the risk of suicide attempts. Cognitive function is impaired, as is concentration and working memory. It's believed by some that there's a misconception out there that impairment of cognitive function is transient. There's also literature that, or at least written down things that say that that's not true. But I point out to you where this was published. Whoops. Sorry about that. Published in PNAS. That's Proceedings of the National Academy of Science. That's probably the hardest journal to get into if you're not a Nobel laureate. So at least they thought it was worth publishing. What about physical health? American Academy of Neurology has an opinion, and it is that heavy marijuana smoking exposes you to carbon monoxide and other respiratory toxins. It's associated with inflammation of large airways, increased airway resistance, hyper lung inflation, and chronic bronchitis. I really did try to find anything that said smoking marijuana is good for you. Donald Taskin writes a lot about marijuana and its effects, and he reported in 2006 at the American Thoracic Society that if you were a greater than 2-pack-a-day smoker, you had a 21-fold increased risk of lung cancer, whereas if you were a marijuana smoker to the same extent, it was almost protective, less than 1-fold increased risk. Pretty hard. I don't think that ever made it to a real publication. There is an association between marijuana and higher rates of acute myocardial infarction and cardiovascular mortality, and there's a recently reported increased risk of stroke. There are physical changes if you compare heavy marijuana users with controls. Smaller hippocampus, your amygdala is smaller, your cerebellum is smaller. This is both true of adults and adolescents. It's said that hepatitis C patients, marijuana is a risk factor for progression of fibrosis. There's plenty of reports that that's not true, so who knows. There is a cannabinoid hyperemesis syndrome. We've seen it in a couple of our patients. There's a conjunctivitis that seems to be unique to the pollen from marijuana, and it will decrease your reproductive potential. It's probably not a very good way to exercise birth control, but it does disrupt menstrual cycle, suppresses oogenesis, impairs embryo implantation and development. This review article entitled "Does Cannabis Use Increase Risk of Death?" basically concluded that marijuana is associated with higher death rates from motor vehicle accidents, AIDS, and lung cancer. All right, what about the concept of medical cannabis? The first law was apparently passed in California in 1996, and any physician could basically recommend this for treatment of cancer, anorexia, AIDS, chronic pain, spasticity, glaucoma, arthritis, migraines, or anything else you thought it would work for. So it's fairly broad in its use. The real problem with having any science that's worth anything is that the efficacy is very difficult to assess because of lack of uniformity of the marijuana or cannabis preparation being used, method of administration. There's a huge difference in bioavailability between inhaled and taken orally, amount consumed, and how functional the patient is. So what I've talked about mostly in the literature had to do with recreational use, and the studies, there really aren't any studies in coming from the places that have it as, that are approved for medical marijuana. Now, what about the other ingredient I mentioned, cannabidiol? Is it safe? There are short-term studies in healthy volunteers and patients with epilepsy, bipolar disorder, Huntington disease, resistant schizophrenia, and Parkinson's disease, where basically they couldn't say that it worked, but it was tolerable and incredibly safe. What does seem to be understood is that the higher the dose of the cannabidiol, the more likely there will be sedation. It's interesting, it has a biphasic response on immunosuppression, where low doses stimulate your immune system and high doses suppress it. As I'll show you near the end, there are two receptors actually in the body for cannabinoids, phytocannabinoids in particular, and there are probably some endogenous cannabinoids. And lymphatic tissue is one place that one of the receptors resides. Cannabidiol has been tried in Parkinson's disease, where it does have some effect on sleep disorder, dystonia, feeling of well-being, quality of life. It does have a oncologic effect. It's anti-proliferative and pro-apoptotic. It's been used in epilepsy. There are lots of studies from the 70s claiming some efficacy. Cochrane review, however, concluded there were not enough high-quality studies to really draw a reliable conclusion about its efficacy, but they, again, thought it was safe. Others have felt it has promise for really bad epilepsy. So let me digress and just mention what Dravet syndrome is. The other name is myoclonal epilepsy of infancy. A seizure disorder that starts less than 1 year of life, can be triggered by things like heat or fever. The seizures are very resistant to standard therapy. 80% of the individuals afflicted with this have a gene mutation at the SCN1 site. And according to the NIH Office of Rare Disease Research, the long-term prognosis and intellectual impairment is correlated with the frequency of seizures. Decline in cognitive function tends to stabilize after the child's about 4 years old. And an individual with Dravet's has an 85% chance of surviving into childhood. It's a bad thing to have. So, if you don't know, you may know this better than I, the Charlotte Figi story. Charlotte and her brother Chase were born, these twins were born October 18th in 2006. Charlotte's seizures started at about age 3 months. They progressed in frequency and duration, some of these grand mal seizures lasting 2 to 4 hours. She, by the way, does have this SCN1 gene mutation. She was hospitalized repeatedly, tried on every imaginable medication, was on 7 antiepileptics at one point without any benefit. And at age 2, really started to have cognitive decline. Family in desperation took her to a specialist in Chicago. He put her on what's called a ketogenic diet, and actually it helped for about 2 years, and then the seizures returned. At age 5, she was having about 300 grand mal seizures a week. She couldn't walk, talk, or eat. Hospitalized over and over again, had multiple cardiac arrests, some in the hospital, and at one point was DNR. The parents, father was actually a Green Beret, but anyway, they searched the internet and every place they could find any information that might be helpful to their daughter, and finally went to Colorado and bought a kind of marijuana called R4. It was said to be low in tetrahydrocannabinol and high in cannabidiol. And a friend distilled or made some oil out of this R4. They gave it to Charlotte, and basically she started to improve immediately. The difficulty was they bought all there was, which is only a few ounces, and they used it up pretty quickly. So in Colorado, the family came in contact with the Stanley brothers, who were at the time and maybe still one of Colorado's largest marijuana growers. And they were crossbreeding a strain of marijuana that had very little THC, but a good deal of CBD. Actually, the name of the strain was Hippie's Disappointment. And because it worked so well for Charlotte, it eventually became known as Charlotte's Web. So Charlotte's continued to take this oil extract and basically rarely has seizures, walking, riding a bike, talking, and said to be developing normally. So at the top is Charlotte on a bad day before CBD and the way she is now. Said to be age 7. That is not kale. So there are numerous reports that CBD helps with certain things. It's been tried with a lot of anxiety disorders, including PTSD, insomnia, Parkinson's, some psychiatric things. The common theme, though, is THC increases anxiety and CBD decreases anxiety. And CBD is reasonably sedating at higher doses. Another Cochrane review suggested that there was some psychiatric characteristics of CBD. So the CBD has some promise as an adjuvant for a number of things, as an antiemetic to help smoking cessation, opiate-sparing agent, complications of chemo, chemo-induced peripheral neuropathy, and some psychiatric conditions. I wouldn't say that there's great evidence that it's going to work out, but we'll talk about that in a minute. So let me tell you about something called Nabiximols. There is a pharmaceutical company in England who has patented a cannabis compound as an oral spray for mouth spray for multiple sclerosis patients to alleviate neuropathic pain, spasticity, overreactive bladder. The UK, like the United States, marijuana is totally illegal. And They have some special dispensation to be able to grow, to manufacture and market this product. You can think of it as tincture of cannabis. It's about 1-to-1 ratio between THC and CBD. Actually, they've sold to Bayer marketing rights in the UK, with the option of marketing it to the rest of the EU. Novartis is licensed to commercialize in parts of Asia, parts of Africa, and the Middle East. So basically, the Deep Pockets pharmaceutical industry is interested in this, and we'll see whether or not its use sort of changes. It is approved in Spain, the Czech Republic, Germany, Denmark, Sweden, France, and Canada. And for Canada, if you go online, you can find that you can buy this product. Buyer beware. They take your money up front, and then it might be delivered 2 to 3 months later. Of note, GW Pharmaceuticals actually has a phase 3 study going on now in the U.S. for treatment of cancer pain. And it's usually going to be something additive to opioids. It's said to have been fast-tracked by the FDA, which usually means that it will come to market faster, assuming it can show efficacy. Now, what was interesting is I think I Googled Nabiximols, since it's such a strange name, and this article pops right up. It's by Dr. Bastow from pharmacy school in Austin. It's probably the best synopsis of the neurobiology of cannabinoids, the pharmacology of cannabinoids, both THC and CBD, and the synopsis of some of the placebo-controlled trials that have been done for pain management. And I don't know if it ever was published anywhere else, but it pops right up in its entirety if you Google Nabiximols. What about hemp? Well, hemp just is another form, another variety of cannabis. It's sort of like collies and beagles are both dogs, so hemp and other cannabises, they're all from the same plant, essentially. It can be grown in the United States. You have to have DEA approval, and it has to be a variety with no more than 0.3% THC by weight. You can buy the hemp seeds with no problem. It's not regulated at all, and basically the amount bought has increased from about 92 metric tons in 2005 to over 2,000 metric tons a couple of years ago. So there seems to be some interest in it. This actually could be where GW Pharmaceuticals gets their brand of tincture of cannabis. Okay, so what do we talk about? Well, marijuana in any form is illegal in Texas. This is not just for the user, but especially for the supplier, if that's a family member or friend. The main use of marijuana, recreational use, is to induce euphoria. There's essentially no literature to suggest that there is any medicinal use that's worthwhile for THC. There is a large literature to suggest that CBD is safe and actually might have some medicinal value, but there's not any convincing research to date to allow FDA approval. We'll see how GW Pharmaceutical, how their trial turns out. It could be coming to a drugstore near you. Okay, so I think that the comment by Sanjay Gupta sheds a lot of light on this whole subject. Basically, marijuana is restricted because there's little research, and there's little research because it's restricted. And that's all I'm going to say. If there are questions or comments, I'd be happy to hear them or entertain them.
So what happened to the patient?
Which one?
The case at the beginning.
She is in line to get her hip replaced. I'm not certain that the orthopedist was convinced. We'll see.
Are the places that have legalized marijuana, the transplant centers, do they have any stuff going on to look at this? Or like in Colorado, are the transplant centers out there, are the transplant centers?
I wish I knew, but I don't.
The administrators are saying the same thing we say to the patients, which is we can approve you, but the insurance company is likely to decline you. And once the insurance company declines you, that may or may not be something you can overcome.
So as far as UNOS is concerned, if a pre comes back positive for marijuana, are they on hold for 6 months or not?
No, they're not. Every program has the option of setting their own guidelines. And you can encourage marijuana use if you want to. You just have to stick to it. If you get audited, it better be a uniform sort of finding. But no, UNOS doesn't have an opinion.
What's our opinion?
Well, as I said, it used to be a contraindication. It's a relative contraindication at this point, which I think, if you believe in Darwinism, is the right approach. Basically, I think that if it's relative, you have the option of applying it or not applying it, based on the rest of the story, common sense. My personal view is that if somebody who is with a high MEL presents late for transplant consideration and tests positive, I would view that different than somebody with a low MEL that we've followed a long time, has been contracted, and uses marijuana in spite of our advice. I also would say that I think we have to be reasonably uniform in what we do. I don't think the liver program can have one idea of use or not use, whereas kidney and lung, I think, probably would have a different view.
So are there any published studies about marijuana use and outcome with transplant?
Not that I could find. Actually, I started this, I have to admit, with a bias that marijuana use, when you've said stop it and they don't, is a surrogate for noncompliance. And I could not find a study that specifically addressed that, although it's all sort of lumped together with drugs of abuse. If you use a drug of abuse, then your chances of being non-compliant seem to be there. But regarding transplant in particular, livers in particular, I'm not sure.
We have patients sometimes that come up positive and they say that they haven't smoked, but they've been around people that smoke. How true is that? Can they turn it positive being around it and not actually smoking it?
Well, there's secondhand smoke, so I think yes. And I think if you're a chronic user, I don't think we actually know things about, lipid solubility, where there must be some, maybe not. Most of it's metabolized by the liver and by the P450 system. So I think yes, probably that's a possibility. And a lot of it has to do with bioavailability. It's this tincture of cannabis. You can take the same amount orally, but it takes a long time to get what they consider a therapeutic level, and its half-life, it takes about 2.5 hours to get there, whereas inhaled cannabis, it's there in about 8 minutes, and so it's about 10 or 20 times higher concentration than, say, the oral route. So I think secondhand smoke does make a difference. It depends on whether you're a chronic or occasional user. No, Reed, I want to hear what Reed says.
So when we used to have our fungal talks with the infectious disease guys, they had a big concern with if you're smoking it and you're inhaling the smoke, it goes through this plant that likely has fungus on it, and then you have the possibility of inhaling fungus in a transplant patient with very little immunosuppression, or very little immune system. Did you find anything as far as infection risk with non-sterile?
Specifically related to Aspergillus or something else? No. It may be there, but I didn't really look that closely. We have marijuana users, and as far as I know, we've not had a pulmonary fungal infection in any of them. I think ours
There
are.
may have been an anecdotal case on the kidney side, and that's, kidney often does things based on anecdotal evidence, that sparked, and that may be some of Reed's, part of Reed's comment that,
Yeah, I would not, and they're also much more heavily immunosuppressed than, say, livers or kidneys even, and so, lung transplant patients. So, I would say it's not impossible. It's also, the elevators going to the clinic used to be full of Aspergillus too. So, I don't know how you ever prove that. There was one of my colleagues, when I first came here, Ray Burke, did some really nice studies. There was a point in time when Mexico, with the help of the United States, tried to get rid of marijuana by spraying it with paraquat. And so if you were smoking marijuana having been sprayed with paraquat, you probably were going to need a liver transplant.
Dr. Speeg, did you come across anything on, because we get these dire warnings as parents of teens now on synthetic marijuana that's out there on the streets? I don't even know what it is.
That was a previous M&M that I talked about that. Yes, it's bad. There are progressively more and more people showing up in emergency rooms, and that's usually where it hits the news with consequences of synthetic marijuana, and there are a bunch. We'll be admitting a patient today who has fulminant failure, and the only thing that we can find in his history is that he does smoke synthetic marijuana. I think it's, there's nothing good to be said about it, but nothing specific except the case reports of emergency room visits.
And the second question I had is, had your whole talk been on the use of alcohol? Obviously, a lot more research, it would have been a lot more dire, probably, in its consequences.
Well, for the patient that gets caught with a positive drug screen, much more dire.
I just, I think we face in our patients their social and casual use of it, and they're equating, all of those studies are on heavy use, and they equate the social and casual use of it to having a glass of wine on the weekends.
You're absolutely right, and that's sort of why I like the relative contraindication, for the reason I said, that I think that basically, there's a difference in my mind between how well a patient will behave after they get a life-saving transplant, if they follow the rules before the transplant, versus somebody who didn't know. It's addictive, okay? And basically a long-term user is not likely to just say, I'm going to stop.
Thanks
All
for
right,
giving the
thank y'all.
comments.